Now that we have the definitions and statistics out of the way, let's have a look at the classifications of TIAs. They can be classified in many ways, and our guideline chose the emergent, urgent, semi-urgent classification system. And this system was actually the one that was promoted by the Canadian Best Practices, Recommendations on Stroke Care, that came out in December of 2008. You can also classify strokes in different ways. The ABCD2 score system is maybe familiar to a lot of you. Nothing wrong with using that. We have gone with this classification because we felt it was a little easier to remember, and perhaps it reflects the increased urgency that should be used in diagnosing and treating TIAs. So emergent strokes are patients that present to you within 24 hours of the, or emergent TIAs, within 24 hours of the onset of their TIA and have high-risk features. I'll go over those in a minute. Urgent, patients that present within 72 hours of onset of their TIA, or semi-urgent would be the others. So what are emergent TIAs? This is what we're going to concentrate on for the next few slides. In those emergent TIAs, patients present within 24 hours of the onset, and they have 2 or more high-risk clinical features of focal weakness, speech difficulties, symptoms lasting more than 10 minutes, and possibility of age greater than 60 or diabetes. Also, you can enter that category if you have acute, persistent, or fluctuating stroke symptoms, a positive investigation, or, and this is pretty open, other risk factors based on clinical judgment or presentation. In other words, if the clinician thinks it's an emergent TIA, it's an emergent TIA, and it should be treated urgently and managed as such. The reason emergent TIAs are so important to classify is because of the risk of stroke after an emergent TIA. And these are actually pretty conservative numbers. Some studies would indicate they're much higher, but 3% in the next 2 days, up to 6% actually. 5% in the next 7 days, 12% in the next 90 days. The key point being the last sentence on this slide. With the EXPRESS trial, we know that with timely investigation and management, that 90-day risk can be lowered to 2%. That is an incredible reduction, and that is what really calls for the urgent care of all TIAs. Let's look at it in a different way. This is a graphic representation of that EXPRESS trial, and you can see from the purple line there, that was the usual care group. Now, even at usual care, these were patients who were seen in the office by their clinician, were referred, a referral was faxed to a TIA clinic. They were seen in the TIA clinic between 1 and 7 days, and then had their investigations and were put on treatment. It was still a pretty clear pathway to managing and diagnosing a TIA, as opposed to the treatment group, where the TIA clinic did not have an appointment system. The patients were sent immediately to the clinic. They were seen, the majority were seen within 24 hours. They were given their diagnostic tests that visit and started on treatment at that visit. So more than 50% received the treatment within 24 hours. And you can see the difference. As you look to the right of the slide at 90 days, over 10, the recurrence rate in the usual care group was over 10%. In the urgent care group was around 2%. That's an 80% reduction, or in absolute terms, an 8% reduction in the risk of stroke. That's a phenomenal result. Not only was there a decrease in disabling strokes, or in all strokes, there was a decrease in disabling strokes of 80%, and there was a decrease in hospital admissions, hospital days, and hospital admissions for vascular causes. In fact, if you look at the control group, there were over 1,300 hospital admissions for vascular causes, and in the rapid treatment group, 427. So there's a possibility of tremendous cost savings there, along with, obviously, saving of a huge number of strokes. So this brings about the first of our 7 key recommendations. Treat emergent transient ischemic attacks as a medical emergency with investigations completed and treatment initiated within 24 hours of the onset of the TIA. This may be difficult to accomplish in all settings. Certainly there are limitations on access, there are geographic limitations, but it means that when you see a patient with a TIA, generally speaking, to accomplish these goals, they will need to be sent to emergency or even admitted to hospital. They need to be treated as a medical emergency. The timeline, just so you know, for the other cases, the urgent patients that present within 72 hours should be investigated and treated as soon as possible, but certainly within 7 days. The semi-urgent, and this may make up quite a lot of your TIA mimics, these are the less clear cases, but certainly should be settled as soon as possible and within 30 days. So a TIA, what do you do in the first 24 hours? What are we talking about with investigation? Well, you need a CT or MRI to rule out other causes or treatable causes. Carotid imaging, this can be a carotid Doppler, it can be a CT angio or an MR angio. The choice of test isn't so critical as getting the test that can be done within 24 hours. That'll depend on your location, depend on access. And certainly some of the urban centers now, it is actually easier and to get a quick CT angio than to get a carotid Doppler. So whichever test you can get urgently within that 24-hour timeline should be the one you use. You need an ECG, a Holter monitor, if you think there's any chance of an arrhythmia contributing to this TIA, and an echocardiogram if it's indicated. Certainly the blood work there for checking out risks or for helping future treatment decisions is indicated. So, emergent TIAs. In the first 24 hours, the treatment, which should be initiated within 24 hours of onset, is anticoagulants for cardiac or vascular sources, and that would include patients with atrial fibrillation, and antiplatelet agents for all other TIAs as long as you're sure it's not hemorrhage. You need to refer the patient for carotid artery surgery if the carotid artery stenosis is greater than 70%, and if you refer them, that surgery should be accomplished within 2 weeks for the major reduction in stroke care. Now, since Dr. Teal is here, I'm going to turn it over to him for a discussion of strokes. But before he discusses stroke, I want him to comment on how important this is as far as getting that surgery within 2 weeks. And really, is this dramatic reduction in stroke incidence possible with earlier intervention? Phil.